Welcome to this in-depth exploration of uterine histopathology. Today, we're doing a really comprehensive deep dive into the cervix and corpus, specifically for you, the practicing histopathologist.
That's right.
And this deep dive is produced by Dr. Mustafa Anees. Our mission here is pretty straightforward. We want to pull out the most critical, practice-relevant information from some detailed source materials we've been looking at.
Yeah, giving you a solid, structured understanding of both normal findings and, importantly, the abnormal things you might see in the cervix and corpus.
Exactly. And we know there's a ton of information out there on this. It can be overwhelming.
It absolutely can.
So we promise to keep things organized and really focus on the key takeaways, the things that matter for your day-to-day work.
Precisely. We'll navigate through the normal histology first, then look at the whole spectrum of lesions you might encounter, and finally, the classification of tumors in both areas.
Right. Distilling it all down into practical insights.
That's the goal, things you can hopefully apply immediately.
Okay, great. Let's unpack this then, starting with the cervix. And let's begin, as you said, with a solid foundation, the normal anatomy.
Makes sense. So the cervix, that lower part connecting the uterus to the vagina, it's divided into two main regions.
The portio vaginalis.
Right. The portio vaginalis, you might also hear it called the exocervix or ectocervix. That's the part projecting into the vagina. And then there's the supravaginal portion, which is of that vaginal attachment.
And the canal running through it.
That's the endocervical canal. It's opening into the vagina is the external os. And where it meets the uterine cavity, that's the internal os. Simple enough.
Okay. And the lining of that canal, the endocervix.
Ah, that's lined by a specialized glandular mucosa. These are columnar cells, and their job is secreting mucus.
And I remember reading that the mucin itself can vary a bit.
It can, yeah. Depending on where a woman is in her menstrual cycle, the composition of the mucin can change. It's quite dynamic.
Interesting. And just beneath these columnar cells.
Right below them, you find these often quite inconspicuous subcolumnar reserve cells. Small cells, TPA positive.
And these are important because?
Hugely important. They're considered the origin point for squamous metaplasia, for high-grade SIL, HSIL, and even ultimately for squamous cell carcinoma.
Wow. Okay, so they're pivotal.
Absolutely. And another key takeaway here, the glandular epithelium itself, those columnar cells, they show immunoreactivity for estrogen receptors. That's relevant too.
Right. Now, here's something I find really helps with differentials. The glands themselves are not just on the surface. They dip down, right,
Yes.
in vaginations.
Exactly. The endocervical glands are essentially invaginations or clefts extending into the underlying stroma. Usually they're less than 5 millimeters deep.
But sometimes deeper.
Occasionally, yes, they can reach up to a millimeter or even a bit more. Microscopically, you see them as tubules lined by a single layer of cuboidal cells.
And often containing that pinkish secretion.
Yes. Often a dense eosinophilic secretion within the lumen. And for diagnostics, this is critical. Remember their immunoreactivity, PX8, PLX2, and GATA3 positive.
That panel is super helpful for distinguishing them from, say, endocervical adenocarcinoma or other glandular issues.
It really is. A key tool in the toolbox. Now, beyond the usual tissues, sometimes you find ectopic stuff in the cervix.
Ectopic, like what?
Things like cutaneous adnexus, sebaceous glands, maybe even hair follicles, sometimes prostatic-type tissue, what's sometimes called the female prostate.
Really?
Yeah. And even islands of mature cartilage. Recognizing these, especially cartilage, is important so you don't mistake them for part of a malignancy, like a carcinoma or a sarcoma.
Good point. Easy mistake to make if you're not expecting it. Okay, let's move on to metaplasias. These are changes where one cell type replaces another.
Correct. And in the cervix, by far the most common is squamous metaplasia.
Especially in the transformation zone.
Exactly, that's the hot spot. It's where the glandular epithelium, those columnar cells, gets replaced by a stratified squamous epithelium. Over time, it can look pretty much identical to the native exocervix.
And how does that happen? Is it the reserve cells again?
That's the prevailing theory, proliferation and metaplasia of those reserve cells we mentioned.
Okay.
Although, sometimes the mature squamous epithelium from the exocervix can just grow over the endocervical lining, like in healing. That's sometimes called squamous epithelialization.
But people often just lump it all under squamous metaplasia.
Pretty much, yeah. The term is often used broadly.
And it's incredibly common, right? Especially during childbearing years.
Oh, absolutely. You see some degree of it in almost every cervix from women in their reproductive years. It can be just on the surface, or it can dip down into the gland openings.
Now, is that different from Immature squamous metaplasia?
Yes, it has a different look. Immature squamous metaplasia appears as a thicker mucosa, but it lacks that typical layered maturation you see in mature squamous epithelium.
And the nuclei look different.
They do. They tend to be oval, often with these longitudinal grooves, and they're oriented sort of perpendicularly to the surface.
And the immunoprofile is key here too, right?
Definitely. Immature squamous metaplasia is positive for CK13, CK17, and CK18, but, and this is important, it's negative for CK20.
Which is similar to
senile atrophy. Although it was debated in the past, we now know it's a benign metaplastic process. It differs from atrophy mainly because it has more cell layers.
Okay. And what about keratinization, seeing actual keratin layers?
That's often called keratosis or leukoplakia. You frequently see it in prolapsed uteri, mostly on the exocervix. You'll see granular and horny layers develop.
But it's benign.
Completely benign, yeah. Unrelated to carcinoma. Sometimes in that context, you might see these scattered, large, pale cells called peachtoid dyskeratosis.
Good to know. And besides squamous metaplasia, are there other types we should be aware of?
Yeah, for completeness, you should know about others, though they're less common. Transitional metaplasia can occur on the exocervix. And then in the endocervix, you can see tubal, tuboendometrial, and even intestinal metaplasia. And even rarer are things like mucinous, ciliated, and clear cell metaplasia.
Right. Good overview. Let's shift gears now to inflammatory lesions. Cervicitis, that seems incredibly common in practice.
Exceedingly common. Chronic cervicitis especially. You find it microscopically in a huge number of adult women. It usually hits the squamocolumnar junction and the endocervix.
And histologically, you might see?
Hyperemia, edema, some fibrosis, maybe those metaplastic changes we just talked about. The cause can be varied, and often women don't even have symptoms.
But isn't there some subjectivity in diagnosing it? Like, aren't some inflammatory cells normally there?
That's a critical point. Yes, inflammatory cells are normally present right at the squamocolumnar junction. So deciding where normal ends and chronic cervicitis begins can be, frankly, a bit subjective.
Okay, that's helpful context. What about specific infections? Herpes.
Herpes simplex virus infection. Yeah, we see it more often now. Biopsies usually just show nonspecific, often quite intense inflammation, maybe some ulceration.
But the classic inclusions are rare.
Very rare in biopsies, actually. Those multinucleated cells with inclusions are described, but you don't see them often. So diagnosis frequently hinges on immunocytochemistry to detect the viral antigen.
Got it. And chlamydia, the most common STD.
Chlamydia trachomatis, yes.
Yeah.
Microscopically, it usually looks like chronic nonspecific inflammation. You might see some reactive epithelial atypia, maybe prominent lymphoid follicles in the stroma.
But you don't actually see the organisms on H&E.
No, not on routine H&E.
Yeah.
They're hard to spot even in cytology preps. So again, you'd likely need immunocytochemistry or culture for a definitive diagnosis.
And is there a link with CIN?
Well, chlamydial cervicitis can certainly coexist with CIN, but a direct causal link hasn't been definitively proven.
Okay. What other infections should be on the radar?
Well, syphilis can present as a primary chancre on the cervix. Amoebiasis can cause a polypoid or ulcerated mass that might mimic carcinoma rarely. It can even grow on an existing cancer.
Yeah.
And actinomycosis is another one. But you need to distinguish the actual organism from those pseudoactinomyconic radiate granules.
Which are non-infectious.
Right there, the Splendor Hepley phenomenon, just reactive material, not bugs.
Okay. And the sources mentioned a few other less common inflammatory things.
Yeah, a whole list. Foreign body granulomas, bilharziasis, that's schistosomiasis, malakoplakia, ceroid granuloma, localized arteritis, even cervical involvement in systemic diseases like granulomatosis with polyangiitis.
Wow, quite a range.
And papillary endocervicitis, where chronic inflammation just makes the surface look papillary.
Right. And what about the area stellar reaction? That comes up in pregnancy, doesn't it?
It does, yes.
Yeah.
The area stellar reaction can involve the endocervical glands during pregnancy, and it can look quite alarming sometimes.
How so?
You see these striking nuclear abnormalities. The appearance can vary a lot. Vacuolated clear cytoplasm, little tufts projecting into the lumen, hobnail cells, cells with bright pink cytoplasm, thin papillae, nuclear pseudo-inclusions, even cribriform patterns within the glands.
So the key is differentiating it from cancer, specifically clear cell carcinoma.
Absolutely critical. Area stellar reaction won't present as a distinct mass. It lacks that desmoplastic stromal reaction, and it doesn't truly infiltrate the stroma Those are key negative features.
Okay, good distinctions. Is there anything else reactive we need to watch out for, maybe after procedures?
Yes, definitely. After endometrial sampling, you can sometimes see an atypical reactive proliferation of the endocervical surface epithelium.
What does that look like?
It can show epithelial stratification, little micropapillary projections, some squamous metaplasia, hobnail-like cells, and maybe mild cytologic atypia.
So it could be mistaken for...
Well, the features can overlap a bit with microglandular hyperplasia, or worse, it could be misinterpreted as endocervical involvement by an endometrial carcinoma. So clinical context is key, knowing about the recent sampling.
Right. Important pitfall. What about delay? Diffuse laminar.
Diffuse laminar endocervical glandular hyperplasia, DLA-GH. It's a benign proliferation of well-differentiated endocervical glands, but importantly, it's confined to the inner third of the cervical wall.
And it looks sharply demarcated.
Yes, typically a sharp separation from the surrounding stroma, often with chronic inflammation nearby. The main differential there is adenoma malignum.
Which would infiltrate.
Exactly. Adenoma malignum would show stromal infiltration, dysplasia, and more cytologic atypia.
Okay. And briefly, the sources also mentioned necrobiotic granulomas after surgery?
Yes, and florid mesenchymal reactions that could mimic sarcoma post-op. Also, just degenerative myxoid changes in the stroma and ectopic decidual reactions, just things to keep in the back of your mind.
Got it. Okay, let's pivot to something really central. HPV, human papillomavirus, and its role in the lower genital tract.
Absolutely fundamental. So the HPV life cycle starts in the basal cells of the epithelium. As those infected cells mature and move up, the virus replicates.
And the outcome depends heavily on the HPV type.
Critically. Low-risk types like 6 and 11 usually cause low-grade lesions, LSIL or condyloma, with those characteristic cytopathic effects, the coilocytes.
Right.
Whereas high-risk types, especially 16 and 18, can also cause LSIL, but they have the potential to drive progression to high-grade lesions, HSIL, and ultimately invasive squamous cancer.
So HPV genotyping can be useful, but just finding high-risk HPV doesn't automatically mean cancer or pre-cancer, right?
Exactly. That's a crucial message.
Right.
Especially in younger people, the immune system often clears the infection. Many high-risk HPV infections are transient.
And the tests we use, like hybrid capture.
Those liquid-based nucleic acid tests are very sensitive, yes. But the downside is they might pick up virus that's actually non-infectious or was already being cleared by the body.
So, for surgical pathology, P16 immunohistochemistry has become a major player.
A very valuable tool. It acts as a surrogate marker for high-risk HPV infection. What you look for is that characteristic strong, diffuse, continuous, block-like staining nuclear and cytoplasmic.
Starting in the basal layer and extending up.
Typically, yes, at least the basal third extending upwards. This happens because the E7 oncoprotein from high-risk HPV messes with the RB protein.
Which leads to P16 getting upregulated as a sort of feedback mechanism.
Precisely. But, and this is a big but, you absolutely must use rigorously validated protocols in your lab with proper controls every time.
Because it's not 100% specific.
Correct. Other things that dysregulate the RB pathway can also cause P16 staining. And very rarely you might lose P16 expression in late-stage invasive cancer, though that's uncommon in HSIL or in situ adenocarcinoma.
And I think the sources mention E5 mRNA as maybe a better marker of active oncogenesis.
Potentially, yes, because its presence suggests active viral gene transcription. But it's not widely available for clinical use yet.
Okay, so P16 is the main ancillary test right now. Now let's talk tumors. Squamous cell carcinoma and its precursors. We should be using the Bethesda terminology for cytology and last recommendations for surgical path, right?
Absolutely. Adheres to Bethesda for cytology, and the last recommendations, which are Bethesda-based for histology, is key for standardized reporting. CO, squamous intraepithelial lesion.
Though people still understand CIN.
They do. So often a dual diagnosis is helpful in the report. CL first, then the CIN equivalent in parentheses, so LSIL, CIN1, and HSIL encompassing both CIN2 and CIN3.
And that CIN2 versus CIN3 distinction isn't clinically critical anymore.
Generally not considered relevant for management decisions. The distinction can be arbitrary and lacks reproducibility, hence grouping them as HSIL.
Okay, so LSIL or CIN1. What defines that histologically? It's the HPV changes, right?
Coilocytes.
Coilocytes are pathognomonic. You see that clear paranuclear halo, the dense irregular cytoplasm at the edge, and importantly, that enlarged irregular nucleus with the wrinkled membrane and ropey chromatin.
Binucleation too sometimes. Yes, binucleation or multinucleation. It's those nuclear features that really nail the diagnosis of coilocytotic atypia and imply HPV. You have to distinguish the halo from just glycogen clearing, which won't have the nuclear changes.
Right. Now, how does that differ from what happens in high-risk infections that progress?
In high-risk HPV infections leading towards HSIL or cancer, the viral gene expression often gets deregulated. The E6 and E7 oncoproteins become more active.
Inactivating TP53 and RB.
Exactly, which lets the cells proliferate uncontrollably. In this scenario, you often see less production of the late viral proteins like E4, so you might see fewer or no coil sites.
And the virus is more likely to integrate into the host DNA.
That's right. Increased integration, more genetic instability, accumulation of other mutations, and ultimately malignant transformation. But again, it's crucial to stress. Most HPV infections, even high-risk ones, don't do this. They get cleared by the immune system.
Okay, so back to LSIL, CIN1 specifically. Dysplasia confined to the lower third.
Lower third of the epithelium, yes. The proliferation rate is higher than in just inflamed or metaplastic tissue. And most LSIL, apart from classic condylomas, are linked to high-risk HPV types.
And the natural history is mostly regression.
Mostly spontaneous clearance, yes. Only a small percentage progress to HSIL. Persistence of high-risk HPV is the main risk factor for progression.
Is CK7 useful there?
Cytokeratin 7 expression in the transformation zone has been looked at as a potential marker for LSIL progression risk, but it needs more validation before routine use.
Okay. Now, HSIL, CIN23. This is more extensive dysplasia.
Yes, dysplasia involving the lower two-thirds, CIN2, or the full thickness, CIN3, of the epithelium. It might be visible grossly if it's expensive, but colposcopy is the best way to see it.
And microscopically, what are the hallmarks?
High nuclear to cytoplasmic ratio throughout all layers, not just the base. Really striking nuclear atypia, big, dark, irregular nuclei, coarse chromatin, and lots of mitotic activity, including atypical mitosis, sometimes way up in the upper layers.
And P16 comes in handy for borderline cases.
It can be a very useful adjunct if you're struggling to distinguish LSSL from HSIL. That strong, diffuse, block-like positivity really pushes you towards HSIL. But the primary diagnosis is still H&E.
Right, H&E first. And treatment for HSIL is usually local?
Yes, typically local ablation or excision. Things like conization, ILEP, electrodiathermy, cryosurgery, laser, usually done under colposcopic guidance. Very effective.
Okay. What about when it just starts to invade? Superficial invasive squamous cell carcinoma?
Right, this is defined very specifically. Stromal invasion that's 3 millimeters or less in depth from the basement membrane and 7 millimeters or less in horizontal spread. That's FIGO stage IA1.
And why is that category important?
Because its behavior, especially the risk of lymph node metastasis, is much more like HSIL than like more deeply invasive cancer. So treatment can often be more conservative.
What are the microscopic clues that might suggest this early invasion, this microinvasion?
Look for increased cellular pleomorphism, more obvious squamous differentiation, like eosinophilic cytoplasm or intercellular bridges, prominent nucleoli in the atypical cells, and maybe individual cell keratinization within the intraepithelial part, features you don't usually see together in typical HSIL.
And the stroma might react.
Yes, a desmoplastic stromal reaction underneath is a good clue. Increased collagen, maybe some ground substance that stains metachromatically. And crucially, you need to see a definite breach of the basement membrane, with tongues or nests of atypical cells pushing into the stroma.
And studies show the lymph node risk is low at this stage.
Very low, with this minimal invasion depth, which supports more conservative HSIL-like management approaches.
Makes sense. You mentioned the immune response earlier in clearing HPV. Does it also play a role in progression?
Absolutely. Host immune factors are critical. Certain HLA types, part of the MHC system, have been linked to increased susceptibility. And immunosuppression, like in transplant patients or those with HIV, significantly bumps up the risk of CIN and invasive cancer.
And these cervical cancers can be linked to similar ones elsewhere in the genital tract.
Yes, vagina, vulva, anus. Sometimes molecular studies show they're clonally related, suggesting metastasis from the cervix. But interestingly, even then, they often behave more like independent primaries clinically.
Strange. Okay, invasive squamous cell carcinoma proper, what does it look like grossly?
It can vary, exophytic like a cauliflower, or endophytic and infiltrative, or just an ulcerated area.
And staging relies on the AJCC-TNM system, correlating with FIGO.
Correct. Pathologists need to be familiar with the specific criteria for T, N, and M stages, especially the details for T1A1, T1A2, T1B1, T1B2, and then T2 through T4, and the nodal metastasis categories.
And sometimes these are found incidentally.
Not uncommonly, yes. In uteri removed for benign reasons like fibroids, or in cervical stumps left after a supracervical hysterectomy.
Microscopically, you mentioned variants: large cell non-keratinizing, keratinizing, and small cell.
Those are the main morphologic patterns. The small cell type needs careful distinction from small cell neuroendocrine carcinoma, using morphology to immunostains, as the latter behaves differently.
But for the squamous variants themselves, the pattern doesn't really change treatment or prognosis.
Generally not, when matched for stage. They're morphologically distinct, but not clinically significant in that way.
Are there other rarer patterns?
Yes. Things like papillary squamous carcinoma, distinct from benign verrucous carcinoma and acantholytic squamous carcinoma, which can look pseudoglandular. Amyloid deposition is very rare.
How does it typically spread?
It can spread directly to adjacent structures. Lymphatically, the first stops are usually the paracervical, hypogastric obturator, and external iliac nodes. Then, potentially sacral, common iliac, aortic, inguinal nodes.
And hematogenously.
Lungs and bones are the most common distant sites. Ovary involvement is less common.
And distinguishing lung mets from a primary lung squamous cancer can be tough.
It can. Detecting HPV in the lung tumor is very helpful in pointing towards a cervical primary in those cases.
Okay. Treatment for invasive cancer beyond stage IO1, surgery or radiation.
It's typically one or the other, or sometimes combined approaches. Radical surgery or definitive radiation, often with platinum-based chemosensitization. The choice depends on tumor extent, patient factors, local expertise.
So early stages might get radical hysterectomy or radiation chemo.
Right. For staged IRI, radiation alone or combined with surgery give similar results, but usually one main modality is preferred. Surgery might be favored in younger patients to avoid late radiation effects like secondary cancers. Sentinel node assessment is often done during surgery now.
And fertility-sparing options exist.
For very early lesions in women wanting children, yes. Radical vaginal trachelectomy is an option.
What about recurrence, pelvic exoneration?
That's a major salvage surgery for central pelvic recurrence. It involves removing pelvic organs, nodes, maybe bladder or rectum depending on location. Care for intraoperative assessment, including frozen sections of nodes and margins, is vital.
And pathologically, the focus then is on nodes, margins, local extent.
Exactly. Lymph node status remains the single most important prognostic factor overall.
Okay, comprehensive. Let's switch tracks now to adenocarcinoma of the cervix, starting with adenocarcinoma in situ, AIS.
Right. AIS is now well established, especially for the HPV-associated types. Key features are cytologic atypia, hyperchromasia, pleomorphism, plus increased mitosis, and often numerous apoptotic bodies.
Those apoptotic bodies are quite characteristic of HPV, aren't they?
They are. The changes can sometimes be subtle, maybe just on the surface or in the superficial glands.
And the mucin can vary, like normal endocervical or intestinal?
Yes. Intestinal type AIS often expresses CDX2. Most AIs is positive for CEA. You also see a high Ki67 proliferation index, abnormal cell cycle markers, and usually decreased or absent hormone receptors.
And strong P16 positivity is expected.
Strong, diffuse P16 is a hallmark, reflecting the high-risk HPV. Glandular dysplasia, something less than AIS, isn't really a routine diagnostic category.
What's the main differential for AI?
Tubal or tuboendometrial metaplasia. They can have increased NC ratios but lack the significant stratification, atypia, apoptosis, and high mitotic rate of AIs. Plus, P16 is usually patchy, not block-like.
And AIs is often found alongside HSIL.
Very commonly associated with HSIL-CIN23 in the nearby squamous epithelium, especially the HPV-associated types.
What about SMILES? Stratified mucin-producing intraepithelial lesions.
SMILES are uncommon. You might see them with invasive adeno or adenosquamous carcinoma or coexisting with HSIL or AIs. They look like stratified atypical cells, but with abundant intracellular mucin, high proliferation, strong P16, different from HSIL because of the mucin.
And treatment for AIs is usually excision.
Yes, conization or LEAP typically. Reporting the extent on the specimen is important for predicting residual risk.
Okay. Now, invasive HPV-associated adenocarcinoma, that's the most common type.
By far. Grossly, there's nothing specific to distinguish it. Microscopically, the usual type, endocervical adeno, is most frequent, often well-differentiated glands with mucin, but differentiation can vary. Other cell types and patterns can exist, sometimes mixed.
How does it spread? Similar to squamous.
Pretty similar patterns, direct extension to endometrium vagina. lymph nodes like squamous, hematogenous spread, but it has a particular liking for metastasizing to the ovaries, especially if the lower uterine segment is involved.
And those combined endocervical ovarian mucinous tumors are often METs from the cervix.
That's the current thinking, yes. P16 and HPV testing on the ovarian tumor can help confirm that.
Treatment is also stage dependent. Surgery, chemo, radiation.
Yes. Surgery for early stages often combined with chemoradiation for more advanced disease. One point is that there seems to be a higher rate of residual tumor after radiation compared to squamous carcinoma.
And prognosis. Stage, grade, nodes again.
Those are the key factors. Historically, adeno had a worse prognosis than squamous, maybe partly due to including HPV-independent types. Among HPV-associated subtypes, prognosis is fairly similar stage for stage. Nodes are always a bad sign.
What about serous carcinoma of the cervix?
Looks like serous carcinoma, elsewhere uterus, ovary, often papillary, may have samoma bodies, can occur with usual type adeno.
And adenosquamous, mixed adeno and squamous components.
Right. Needs distinct glandular and squamous components, not just squamous with some mucin. Prognosis isn't significantly different from pure types, grade for grade, stage for stage.
Glassy cell carcinoma, that's a specific variant.
Yes, a distinct, poorly differentiated type of adenosquamous. Often younger women may be associated with pregnancy. Cells have that ground glass cytoplasm, prominent membranes, big nucleoli, lots of mitosis, usually a big inflammatory infiltrate, often with eosinophils.
Okay. Now, gastric type adenocarcinoma, that's HPV independent.
Yes, and generally has a poorer prognosis. Tends to invade deeply. Looks like large glands, lots of mucin, cells with apical snouts or hobnail appearance, often relatively bland nuclei despite the aggressive behavior.
And P16 negative.
Usually negative or just patchyfocal. Often CEA positive, ER negative, CDX2 is positive in about half. Can look quite variable within the tumor. Single cell invasion, signet rings at the edge are sometimes seen. Tends to present later than HPV-associated types.
And adenoma malignum is a super well-differentiated version of that.
Exactly. Minimal deviation adenocarcinoma. Very well-differentiated gastric type. Malignancy might only be obvious from the distorted, deep glands with irregular shapes infiltrating the stroma, often with minimal reaction. Bland cytology means it often takes multiple biopsies to diagnose.
Can have less differentiated areas.
About half might have small foci that are poorly differentiated. Vascular perineural invasion can occur. CEA positive helps distinguish from microglandular hyperplasia. HIK-183 is a potential marker, but not standard. Differential includes endocervical adenomyoma.
What about mesonephric carcinoma?
Extremely rare. Most older reports were likely misdiagnosed Müllerian or yolk sac tumors. True ones often arise near mesonephric hyperplasia, which might be atypical. Variety of patterns: ductal, tubular, retiform, solid, sex cord-like, spindle, immuno, CD10, J3, calretinin positive. There are also malignant mixed mesonephric tumors, also super rare.
And clear cell carcinoma, Müllerian origin now.
Yes, Müllerian, not mesonephric. Glands, papillae, tubules, solid sheets, hobnail cells. Clear or eosinophilic cytoplasm due to glycogen. Typically ER/PR negative, but HNF1 and PX8 positive. Aggressive tumor.
Neuroendocrine carcinomas, small cell and large cell, HPV associated.
Yes, similar age group and HPV association as squamous. Carcinoid syndrome is not typical, though some endocrine paraneoplastic syndromes can occur. HSIL nearby is uncommon.
Histology is like neuroendocrine tumors elsewhere.
Identical. Large cell has organoid, trabecular patterns, etc. Small cell is monotonous. Small cells, scant cytoplasm, hyperchromatic nuclei. Mostly pure, sometimes combined with adenosquamous. Immuno shows CD56, chromogranin synaptophysin, but can be variable.
TTF1 isn't helpful for ruling out lung mets.
No. But P16 positivity suggests HPV association, pointing towards a cervical primary.
Okay, and the sources listed a whole bunch of other rare cervical tumors.
Yeah, briefly. Verrucous carcinoma, spindle cell carcinoma, undifferentiated carcinoma, adenoid cystic, adenoid basal can be mixed. Carcinoma with sebaceous differentiation, mucoepidermoid, small cell with rhabdoid features, lymphoma, primary rare, melanoma, primary rare.
And metastatic tumors.
Metastases to the cervix, yes. Most common origins are ovary, large bowel, stomach, breast, kidney. Can mimic primary tumors. Clinical history is vital. There was even a case mentioned of metastatic appendiceal mucinous tumor replacing the endocervix.
Wow. Okay, one last point on the cervix. Cytology, the pap smear. Terminology evolved from Pipeniculo classes to CIN to Bethesda.
That's the progression. Bethesda system, SL, SIL, HSIL carcinoma is the standard now for reporting squamous abnormalities. Management flows from those results: repeat cytology, colposcopy, HPV testing.
And even though primary HPV testing is coming in,
Cytology remains critical. especially for interpreting abnormal results. The Pap test has been incredibly successful. But we have to remember, even with co-testing primary HPV screening, vaccination cervical cancer won't disappear entirely.
Especially the HPV-independent adenocarcinomas.
Exactly. They're a different challenge.
Okay, that covers the cervix in great detail. Let's move up to the corpus of the uterus. Again, starting with normal anatomy.
Right. The adult uterus before pregnancy is pear-shaped, weighs maybe 40, 80 grams, about 7, 8 centimeters long, divided into cervix below and corpus above.
And the top part is the fundus.
Fundus is the rounded top, above where the fallopian tubes insert. The corners where the tubes enter are the cornea, and the bit connecting corpus to cervix is the isthmus or lower uterine segment.
Inside, you have the uterine cavity lined by endometrium, then myometrium, then serosa.
Correct. Endometrium is the inner lining, myometrium the thick muscle wall, serosa the outer peritoneal covering.
How do you tell anterior from posterior on a gross specimen?
Couple of clues. The peritoneal reflection dips lower down on the back, posterior. Also, the fallopian tubes insert slightly posterior to where the round ligaments attach.
Okay. Key topics for the corpus will be endometrium hyperplasia, carcinoma, leiomyosarcoma, endometrial stromal sarcoma, and TCGA is relevant here too.
Very much so. Endometrial biopsies and curettings are incredibly common specimens. Pathology ranges hugely hormonal effects, inflammation, polyps, hyperplasia, carcinoma. Endometrial cancer is the most common GYN malignancy, and the genomic subtypes from TCGA are really changing how we think about it. Plus sarcomas, adenosarcoma. Lots to cover.
Let's start with hormonal effects. Unopposed estrogen.
That's a classic cause of endometrial hyperplasia, and that hyperplasia can progress to atypical hyperplasia and then often to a well-differentiated superficial endometrioid adenocarcinoma, usually with a good prognosis.
What about progestins? Used a lot therapeutically and for contraception.
Progestins primarily affect the stroma. You see really striking pseudodecidual changes. The stromal cells look like decidua. The glands, meanwhile, tend to become small, far apart, often atrophic looking.
And the Mirena coil, that's levonorgestrel.
Right, that induces a whole spectrum. Pseudodecidualization, sometimes mucinous change, ulceration, inflammation, hyaline nodules, micropapillary changes, even infarcted decidua or calcification. Lots of possible appearances.
Progesterone receptor modulators. For endometriosis or fibroids.
They usually cause minimal endometrial change. Maybe some cystic dilated glands with inactive lining, abortive vacuoles, abnormal stromal blood vessels.
Okay. Tamoxifen. Used for breast cancer, but has estrogenic effects on the endometrium.
Paradoxically, yes, without ovarian estrogen. It does increase the risk of hyperplasia, polyps, and malignancy, but not enough to warrant routine screening biopsies in asymptomatic women.
And the changes aren't specific.
No pathognomonic changes. You diagnose hyperplasia or cancer using the same criteria as in non-tamoxifen users. Whether tamoxifen-associated cancers are higher grade is debated. Some studies suggest yes. Others suggest mostly low-grade endometrioid. Could be selection bias.
Are there other hormonal-related things like decidual reaction without progesterone?
Yes, idiopathic decidual reaction can happen postmenopausally. Normally, postmenopausal endometrium is inactive, simple glands, cuboidal lining, dense stroma, or atrophic, thin lining, minimal stroma. Cystic atrophy just means dilated glands with flat lining. These distinctions aren't usually clinically critical.
But postmenopausal bleeding specimens are common.
Very common. Usually shows inactive atrophic changes, but maybe 5–15% will have carcinoma, and a similar number might have polyps. Unexplained bleeding might be related to degenerative vascular changes.
Ariostella can happen in the endometrium too.
Yes. And stromal metaplasia, smooth muscle, cartilage, bone, sometimes related to retained fetal parts. Mucinous or clear cell metaplasia can occur too. Importantly, vascular involvement in metaplasia doesn't automatically mean malignancy.
Okay. Endometritis inflammation of the endometrium. Acute first.
Acute endometritis is usually related to abortion, postpartum state, or instrumentation. Gonococcal is usually transient. Key point. Neutrophils are normal in the stroma on days 26–28, so don't call that acute endometritis.
Right. Chronic endometritis. Lymphocytes and plasma cells.
Yes, plasma cells are the key. Eosinophils might be there too. Causes include post-pregnancy abortion, IUDs, submucosal fibroids, PID. It's linked to infertility implantation failure. Antibiotics sometimes help IVF outcomes.
Symptoms are often asymptomatic.
Can cause bleeding or pain, but often asymptomatic. Lymphoid follicles alone aren't enough for the diagnosis that can be normal. You really need to find those plasma cells.
And immunostains can help find them, CD138.
Yes, stains for plasma cell markers like CD138, Syndicin-1, CD38, or immunoglobulins can confirm their presence. But remember, scattered plasma cells can be normal, especially near the basalis. You need a significant number, often in aggregates. Look for stromal changes, spindle, or stellate cells that suggest inflammation, then hunt for plasma cells. Criteria still need refining.
IUDs often cause chronic inflammation.
Very commonly, yes.
Huh?
Focal or extensive, sometimes with necrosis or squamous metaplasia, can lead to PI abscess. Need to distinguish actinomyces colonies associated with IUDs from those pseudoactinomycotic granules, and Mirena has its own specific progestin effects we mentioned.
Other types of endometritis?
Post-ablation granulomas, malakoplakia, rare, can occur with cancer. Sarcoidosis, diagnosis of exclusion. Granulomas after hysteroscopic resection. Giant cell arteritis, elderly. Isolated vasculitis. Pyometra, pus due to obstruction, often benign stricture postmenopausally. Hematometra, blood accumulation can cause xanthogranulomatous endometritis.
Okay. Adenomyosis and endometriosis, ectopic endometrial tissue. Adenomyosis is within the myometrium.
Correct. Endometrial glands and stroma deep in the muscle wall. Usually basal-type endometrium, often connected to the surface basalis. Rare postmenopausally unless on tamoxifen. Then might see fibrosis, dilated glands, metaplasia.
What about stromal adenomyosis?
Small islands, mainly of stroma, maybe sparse glands. Need to distinguish from endometrial stromal sarcoma, which forms larger foci.
And endometriosis is endometrial tissue outside the uterus?
Exactly.
Oh.
Glands and stroma in ectopic locations, usually functional layers so they can cycle. Tends to be more proliferative than normal endometrium, can persist postmenopausally. Very common cause of pelvic pain, infertility.
And it can show up almost anywhere.
Pretty much. Ovary, tubes, ligaments, bowel, bladder, peritoneum, hernia, sacs, lymph nodes, skin, especially umbilicus, C-section scars, lung, pleura, even nasal cavity.
Wow. And membranous dysmenorrhea.
Painful passage of an entire endometrial cast, usually decidualized, related to a hyperprogestational state.
Dysfunctional uterine bleeding due to an ovulation. What does the endometrium look like?
Often shows what's called exuberant disordered proliferative endometrium. Glands are irregular, more complex than normal proliferative, but not crowded like hyperplasia, and no significant atypia. Mitosis, maybe some abortive vacuoles or apoptosis, common in PCOS, puberty, perimenopause.
But the distinction from normal proliferative or hypoplasia without atypia can be tricky.
It can be subjective. Best to diagnose disordered proliferative only when it's clearly abnormal. We'll discuss hyperplasia next.
Okay, endometrial hyperplasia. Defined by increased gland-to-stroma ratio, irregular architecture, using the WHO 2014 classification.
Yes. Two main categories. Hyperplasia without atypia can be simple or complex, and atypical hyperplasia, also simple or complex.
What about papillary proliferation, PPE?
That's a pattern with prominent papillary architecture, but minimal cytologic atypia. Papillae can be simple or complex. Crucially, no significant nuclear atypia. That's a distinction from papillary carcinoma. Lining is usually single layer, pale eosinophilic or mucinous, maybe ciliated, often in polyps. PPE does have malignant potential, can progress to endometrioid carcinoma.
Can hyperplasia show secretory changes or squamous metaplasia?
Yes, to both. Secretory changes like subnuclear vacuoles, stromal predecidua, gland cell clearing can occur. Squamous metaplasia can be diffuse non-keratinizing, adenoacanthosis, or form berry-like morals, morular metaplasia. More common premenopausally with hormones, PCOS. Frank keratinization, ichthyosis uteri, is rare.
Curettage and biopsy reports. Language can be variable for benign findings.
It can. Cancer reporting is more standardized. We don't really try to date the endometrium for ovulation anymore. Clinicians mainly want to rule out polyps, endometritis, hyperplasia, or cancer, especially in infertility workups.
So standardized benign terminology would be helpful.
Definitely. Suggestions include categories like non-diagnostic, scant inactive, inactive atrophic, proliferative, normal weak disordered, secretory, normal disordered, hyperplasia without atypia, simple complex, atypical hyperplasia, simple complex, polyp.
What about adequacy? When is a biopsy insufficient?
Insufficient really only means no endometrial tissue present. Scant atrophic tissue in a postmenopausal woman is a finding, not insufficient. Some suggest 010 strips is adequate, 10 suboptimal, but that needs more validation. Maybe categories like adequate, benign suboptimal, insufficient.
Okay. Endometrial polyps. Localized protrusions.
Yes. Epithelial and stromal components often show secondary changes like vascular insufficiency. In curatings, you might suspect a polyp, If the stroma looks different, often less cellular, more fibrous and spindle-shaped than background endometrium. Glands are often cystic, lining can be active or flat inactive postmenopausal. Abnormal glands can occur.
More common with tamoxifen.
Yes, often multiple, large, fibrotic, may show stromal decidualization or mucinous metaplasia on tamoxifen.
What about just normal secretory endometrium that looks polypoid?
Yeah, polypoid secretory endometrium or secretory pseudopolyp, no standard term, common finding.
And adenomyomatous polyps contains smooth muscle.
Right, smooth muscle integral to the polyp, not just pulled in from the wall. Polypoid adenomyomas tend to be hard, grayish.
Okay, let's tackle endometrial carcinoma. Bachman's two types, type I estrogen-related, type 2 not.
That's the classic model. Type 1, linked to estrogen excess, often arises from hyperplasia, typically low-grade endometrioid, more common. Type 2, thought to arise de novo, not estrogen-driven, older women. Serous carcinoma is the prototype. CUB2 doesn't have strong risk factors, maybe rare BRCA links.
But TCGA has given us molecular subtypes now.
Yes, 4 main ones. 1, CN low P53 wild type, mostly type I endometrioid. CN high PV3 abnormal, includes type 2 serous, high-grade endometrioid. 3, MMRD hypermutated, microsatellite unstable, mostly endometrioid. 4, POL EDM, ultramutated, often endometrioid, can be high-grade.
But histology still drives the report, grade and histotype.
Absolutely. The correlation with molecular subtypes isn't perfect. Pathology reports still focus on grade and histotype.
Let's talk about MMR deficiency, MMRD, detected by loss of MMR protein staining.
Yes, IHC for MLH1, MSH2, MSH6, PMS2 is the screen. MMRD is seen in Lynch syndrome cancers. 3–4% of endometrial cancers, often younger women, higher grade, TILs, mostly endometrioid.
But it can also be somatic, not inherited.
More commonly, yes. Often due to MLH1 promoter methylation, usually in older patients, more likely endometrioid or mucinous, often with TILs too.
Where do these cancers arise? Anywhere in the lining.
Any region. Younger women tend to have more in the lower uterine segmentismus. These are still considered endometrial primaries. Small ones in the cornea can be missed.
Microscopically, most are conventional endometrioid adenocarcinomas, graded 1, 2, 3.
About 80% are. Grade 1, well diff, 50%. Grade 2, mod diff, 35%. Grade 3, poorly diff, 15%. FIGO grading uses gland solid ratio and nuclear atypia. Grade 1 and 2 often grouped as low grade as prognosis treatment is similar.
Better differentiated ones resemble normal proliferative endometrium, endometrioid.
Yes, and over a quarter have papillary viloglandular areas. Need to distinguish those from aggressive serous carcinoma. Endometrioid can also have small, non-villous papillae. Superficial parts might look less differentiated.
Uterine serous carcinoma can coexist with endometrioid, arise in polyps, be minimal.
Yes to all. Even if confined to a polyp, minimal uterine serous carcinoma, it can still spread outside the uterus. Endometrial glandular dysplasia might be a precursor. Most high-grade series involving endometrium are primary uterine. WT1 is less consistently positive than in ovarian serous. Stage is endometrial.
And P53 staining is key for serous.
Abnormal P53, strong diffuse mutation type staining or complete absence null pattern, is characteristic of serous. But it's not 100% sensitive or specific. About 30% of high-grade endometrioid also show abnormal P53.
So helpful but not definitive.
Right. In ambiguous cases, more atypia than low-grade endometrioid, but not classic serous, abnormal P53 strongly favors serous. Molecularly, serous is almost always in that CN high 53 abnormal group.
What about carcinosarcomas, malignant mixed Müllerian tumors?
MMD.
Biphasic?
Yes. Mixture of carcinoma and sarcoma-like elements, usually with an abrupt transition. Mimics include dedifferentiated carcinoma or endometrioid with CHEC pattern. Carcinoma part is usually glandular, often high-grade papillary serous is common. Sarcoma part can look like native tissue, homologous stromal, smooth muscle, fibrous, or non-native, heterologous muscle, cartilage, bone, fat.
Need to look carefully for sarcoma if you see high-grade carcinoma with necrosis hemorrhage.
Definitely. Sarcoma part can overgrow or be subtle, metastases usually epithelial, but can be mixed or pure sarcoma. Rhabdoid component is rare.
Immuno shows keratin in carcinoma, less none in sarcoma.
Typically, yes. Genetically, they can have type I or type 2 pathway alterations, maybe representing end-stage progression. Rare in MMRD or PSRKDs.
And they're very aggressive.
Highly aggressive, generally worse prognosis than high-grade carcinoma stage for stage. Spread easily. Maybe slightly better prognosis if sarcoma is homologous versus heterologous, but stage usually outweighs that. Diagnosis is still H&E based. Wild-type P53 can help lean towards low-grade endometrioid in ambiguous glandular cases.
How does endometrial cancer spread? Myometrial invasion depth is critical.
Yes, direct spread into myometrium, stages at 50% or 50% thickness, and cervix is prognostic. Measuring invasion depth can be tricky. Arcuate vessels are a rough guide. Deep cervical invasion is bad. Lymphatic spread to pelvic para-aortic nodes, hematogenous to lung, litter, bone, vagina.
Synchronous endometrial and ovarian cancers, often endometrioid.
Yes, often endometrioid, often clonally related. Staging is tricky. For low-grade endometrioid without high-risk features, often treated as independent stage I primaries. High-grade tumors usually assume ovarian is metastatic unless proven otherwise. Features favoring mests to ovary, bilateral multinodular surface implants, LVI, and ovary.
Standard treatment is hysterectomy plus BSO, staging nodes sometime.
Yes, TAH, BSO is standard. Surgical staging nodes at 50% invasion, grade 3, cervical spread, Estrogen disease, unfavorable histology, or big nodes. Radiation less used now except for high recurrence risk.
Okay, endometrial stromal tumors, middle-aged women.
Yes. Average age 45, often present with bleeding. Low-grade ESS looks like uniform small stromal cells. Prominent reticulin around cells, spiral arterioles, mitoses variable. Invades myometrium often, nodes rare.
Plexiform tumor tumorlet.
Incidental, small, 1 centimeter benign, uncertain origin stromal, biofibroblastic, smooth muscle.
Can stromal tumors have gland-like areas?
Yes, epithelium-like formations, sometimes with odd symplastic nuclei, papillary patterns.
Malarian adenosarcoma, low-grade benign glands, plus sarcomatous stroma.
Correct. Stroma is highly cellular. Sarcomatous overgrowth can happen. Worse prognosis. Looks a bit like breast phyllodes tumor. Usually perimenopausal, postmenopausal, presents as bleeding polyp. Can invade. Mets rare. Sarcoma part. Treatment is hysterectomy.
Leiomyomas fibroids, most common uterine tumor, benign smooth muscle.
By far. Single or multiple, variable size. Can be asymptomatic or cause bleeding, pain, pressure, infertility. Grossly. Well-circumscribed, firm, whorled, submucosal, intramural, or subserosal.
Microscopic features, uniform spindle cells.
Bundles of uniform spindle cells, scant cytoplasm, cigar-shaped nuclei, phenomitosis. Reticulin around individual cells. Hard to diagnose definitively from curatings unless fragments show increased cellularity or hyaline change. Can't tell submucosal from superficial myometrium easily.
Treatment varies. Observation to hysterectomy. Medical options.
Yes, observation if asymptomatic. Myomectomy or hysterectomy is symptomatic for fertility desired. GnRH analogs, leuprolide, shrink them but don't cause a tibia. Uterine artery embolization causes necrosis calcification. Tranexamic acid linked to infarct-type necrosis.
Lots of secondary changes are common. Hyaline, myquosioid, cystic.
Very common. Hyaline is most frequent, over 60%. Myxoid calcification, cystic, fatty changes too. No real symptom correlation.
And unusual variants exist. Lipoliomyoma, IV leiomyomatosis, bizarre, epithelioid.
Yes, quite a list. Lipoliomyoma, fat. Intravenous leiomyomatosis grows in veins. Disseminated peritoneal leiomyomatosis, benign metastasizing leiomyoma, usually lungs. Bizarre symplastic, nuclear pleomorphism, low mitosis. Epithelioid, sheets of round cells. Mucoid, lots of ground substance. Cellular, packed cells, low mitosis.
But leiomyomas don't become leiomyosarcomas.
No known molecular progression. Leiomyosarcomas arise de novo, have complex genetics.
Okay, leiomyosarcoma, malignant smooth muscle, rare, older women.
Yes, rare. 1% uterine malignancies, usually postmenopausal. Bleeding, pain, mass. Grossly, often soft, fleshy, hemorrhagic, necrotic.
Microscopic criteria are key. Necrosis, mitoses, pleomorphism.
Yes, in that order of importance. 1. Coagulative tumor cell necrosis. Abrupt transition, most important. 2. Mitotic activity, count per 10 HPF, but reproducibility issues exist. 3. Pleomorphism, nuclear variation. 4. Cellularity, subjective least important. Tumor borders, infiltrative, also helpful.
So necrosis, mitosis, pleomorphism.
Generally how they're weighted. Most are overtly malignant anyway. Need strict criteria for mitoses.
Spread, treatment, prognosis.
Can spread locally, distantly, lung, bone common. Aggressive, most stage-I patients die. Nodes rare. Treatment is TAH-BSO. Prognosis depends on stage, necrosis, mitotic count, 10-10 HPF, usually malignant, pleomorphism.
But some cases are difficult to classify. STEM-MP.
Yes, smooth muscle tumor of uncertain malignant potential exists for borderline cases. Ideally, we'd have a system predicting risk based on all features, but for now, we use current criteria.
PEComa, perivascular epithelioid cell tumor. Rare. Associated with tuberous sclerosis.
Yes, rare mesenchymal. Related to vessels.
Yeah.
Epithelioid type. Can be benign or malignant. Criteria still evolving. Uterus most common GYN site. Can resemble smooth muscle tumor grossly. Microdotepithelioid plus spindle cells.
Immunohelps, HMB-5 positive.
Consistently HMB45 positive. Minority Milan Amatia plasopia. Smooth muscle markers often positive too. Malignancy features. 5 centimeters, infiltrative, high-grade nuclei, cellularity, mitosis, 150 HbF, LVI, necrosis. Absence of all suggests benign. One feature, uncertain potential. U2 features, likely malignant.
Inflammatory myofibroblastic tumor, IMT. Also rare, benign low grade.
Yes, uncommon in uterus. Young middle-aged women. Fleshy mass can mimic malignancy, microspindle cells, myxoid collagenous stroma, inflammation, often plasma cells. ALK positivity is key for diagnosis, distinguishes from smooth muscle. Most benign low grade, but some can be aggressive.
Okay, last major topic. Gestational trophoblastic neoplasia, GTN, from pregnancy. Moles, choreo.
Right, proliferations of trophoblast, hydatidiform mole, complete, partial invasive, placental site, trophoblastic tumor, PSTT, choriocarcinoma. Pathogenesis involves genomic imprinting in moles.
Hydatidiform mole, complete versus partial.
Complete mole. Diploid, all paternal chromosomes, no fetus. Diffuse hydropic villi, circumferential trophoblast hyperplasia. High HCG, the tediglutine cysts common. P57 stain is negative focal and stromal cells. Partial mole. Triploid, usually diandric. May have fetus-fetal parts RDCs. Focal hydropic villi, less trophoblast proliferation. Lower HCG, no epiglutein cysts. P47 stain is positive in stromal cells.
Diagnosis often from DNC. Need to distinguish from hydropic abortion.
Yes. Hydropic abortion has less trophoblast proliferation, no circumferential hypoplasia. P57 employee analysis flow molecular. Help in tricky cases.
Invasive mole. Mole invading the myometrium.
Yes, usually a complete mole. Villi penetrate deep into muscle vessels. Exaggerated invasion. Happens in 16% of complete moles. Can embolize the lungs, vagina, brain, still produce HCG. Risk of hemorrhage. Treat with chemo, sometimes hysterectomy.
Choriocarcinoma, most aggressive. Follows mole often.
Yes, most aggressive. 50%. Follow complete mole, 1 to 2% risk. Proliferation of syncytiotrophoblastic and cytotrophoblastic, grossly hemorrhagic, microstreaming masses of both trophoblast types. No vilblast present, key feature.
Immunometastases.
HCG plus R, keratin plus dye, maybe HPL, SP1, CEA. Minor intermediate trophoblast component possible. Early bloodborne, Mets common, lung, brain, liver, kidney, bowel. Untreated prognosis poor, but highly chemosensitive.
PSTET, often chemoresistant though.
Placental site trophoblastic tumor, PSTT, for intermediate trophoblast. Yes, from implantation site intermediate trophoblast, uterine or extrauterine, reproductive age usually, abnormal bleeding, HCG elevated but lower than choreo, solid cystic mass, micro, uniform intermediate trophoblast, nest masses, necrosis hyaline, can mimic carcinoma. Immuno, keratin plus ABIN plus A and EMA plus EAP63 plus ALAs, HLAG plus A, ecadherin plus A focal ACG. Chemo, often ineffective, hysterectomy preferred.
Epithelioid trophoblastic tumor, ETT. Also rare, intermediate trophoblast.
Yes, rare. Can arise post-mole, abortion, de novo, or in choriomets after chemo. Similar age presentation to PSTT. Location can be endometrium, myometrium, cervix, broad ligament, even lung primary. Micro also nest masses of intermediate trophoblast, necrosis, hyaline, also mimics carcinoma, immunosimilar to PSTT.
Okay, just briefly, other rare corpus tumus conditions.
Myxoid change in myometrium, degenerative. Adamatoid tumors, mesothelial, look like fallopian tube, usually subserosal near cornua. A fistula, pulsating mass. Benign mesenchymal. Hemangioma, solitary fibrous tumor. Lipoma. Rare sarcomas. Chondro, osteorhabdo, MPNST, angiosarcoma. MFH, malignant mesenchyma. Alveolar soft part, GIST. Rhabdoid. Ewing peanut. Neuroectodermal tumors without UWSR1 rearrangement. Some sarcomas are post-radiation.
Wow, a huge amount covered. So, to wrap up this deep dive.
We've really gone through the histopathology of the uterus, cervix, and corpus, from normal structure to inflammation, metaplasia.
The critical role of HPV, especially in the cervix.
And then a pretty comprehensive look at the benign and malignant tumors, their classification, morphology, key diagnostic points.
And the aim, again, for this deep dive produced by Dr. Mustafa Anees was to give you, the histopathologist, a solid, structured handle on this material based on detailed sources, focusing on what's relevant for practice.
Hopefully it provides a good framework. We encourage you to reflect on how this fits with the cases you see every day, especially the challenging ones.
Definitely. And maybe explore specific areas further based on your own practice needs or interests. Or there's always more detail to uncover.
Absolutely.
And a final thought to leave you with. This field is constantly evolving, isn't it? Especially with molecular advances really changing how we classify and understand these diseases.
It really is. Staying updated, critically evaluating new diagnostic criteria, integrating molecular findings where appropriate, it's all essential for providing the best diagnoses.
Couldn't agree more. Continuous learning is key. Well, thank you for joining us on this deep dive.